Thank you to everyone who's joined us this evening for our anaesthesia webinar. I know many of you are familiar with the VVS service and the VVS team, but for those who are not, I'll be giving a brief introduction before we move on to Nicki's webinar. So you may have used some of the VVS disciplines already in your practice. We now have 11 disciplines available from our brilliant friendly specialist team. So as well as cardiology and diagnostic imaging, which you may have used already, we also have neurology, feline medicine, dermatology, and now as of today, we're really excited to say we also have anaesthesia available. For those of you with a VVS workstation, I'm sure you're familiar with the VVS services available to you. Hopefully you've experienced one of our live guided cardiac workups or maybe our abdominal ultrasound. Also available are our specialist advice calls and written reports for which you don't need the workstation. So any branch clinic or any smaller clinic that doesn't have the workstation can use these services with no need to register or subscribe. So from bespoke oncology protocols to ECG analysis, radiology reports to internal medicine advice calls. All of this, you can quickly and easily access this from your consulting room. All you need to do is complete our refer a case form online and we'll be in touch to organise this for you at a convenient time. You can also email any one of the team at info@vvs.vet and we'd be really happy to help you. And if anyone has any inquiries after tonight's webinar, do just drop us an email. So today, we're really lucky to be joined by Dr. Nicki Grint, new VVS anaesthesia specialist. Nicki graduated from Bristol in 2000 and stayed on to undertake an internship and then residency in veterinary anaesthesia. She completed her PhD on pain processing and analgesia in 2012 and holds the RCVS certificate and diploma and the European diploma in veterinary anaesthesia. She's worked in both private and university referral hospitals in senior anaesthesia positions and is currently an independent veterinary anaesthesia consultant. We are so pleased to have Nicki join the VVS team and share her expertise and knowledge with us. Tonight, Nicki is leading a webinar on the hugely relevant topic for general practice of obese patients, the challenge for the anaesthetist. So without further ado, I'll hand over to Nicki for tonight's wonderful webinar.
Thank you. Right, great. Well, thank you so much for the introduction and for such a warm welcome to your team. So good evening, everybody. And this is my first inaugural webinar as the anaesthesia consultant for virtual veterinary specialists. I'm so excited to join the team. In this presentation, we're going to be discussing considerations when anaesthetizing the obese pet. So tonight, I hope you're not disappointed. I'm not going to give you any recipes or anaesthetic protocols because we know that we are going to see obese pets for all kinds of reasons, for all kinds of procedures. But what I am going to do is take you through all the things you need to think about when planning an anaesthetic, the challenges that you might face and clinical ways that we can overcome those challenges. So that being said, I am able to help you out as part of the VVS service with plans for individual cases. And that's one of the things I can do as part of the VVS team. So for those complex anaesthetic cases that you want to chat through, you want to get a plan for, and I can make it really bespoke to you, also the individual animal, but also for your clinic's facilities and drugs availability as well. So that's just one of the things that I can offer. I'll be pointing to a couple of others as we go through our presentation, but let's get back to that for the minute. So what is obesity? Obesity is defined as the excessive body fat content sufficient to cause impairment to health or bodily function. And estimates of obesity in the veterinary literature shows a prevalence in dogs ranging between nearly 2% and 10%, depending on the paper that you read, with the definition of obesity being dogs or cats that score 5 out of 5 on body condition score, or out of a 9 body condition score, a score 8 or 9. But then once you include overweight animals in the statistics, with overweight animals being classified as those with a body condition score of 6 or 7 out of 9, we're looking at almost half of the population of small animal patients presented to vets being classified as overweight or obese. And certainly in a canvassing questionnaire, many vets and vet nurses in the UK felt that the number of dogs seen in their clinics over the past 2 years that are overweight or obese has increased exponentially. Lockdown probably also hasn't helped. But can we put a number on this increased risk of anaesthesia for obese patients, because I think we all recognise that there's this increased risk, but is there actually a number that we can put on it and talk to clients about? And yes, there is an increased risk, but when looking through the literature, I couldn't find many studies that actually could put a number on it. The only one that I could find was the SEPSAF study. So those of you who are as long in the tooth as I am, so I've been an anaesthetist now for 20 years, may remember taking part in the SEPSAF study. This is the confidential inquiry into perioperative small animal fatalities. And so Dave Broadbelt, as part of his PhD thesis, sent a questionnaire around lots of hospitals and veterinary practices in the UK, asking for case details of patients that were anaesthetised, and particularly cases where, sadly, animals died around the time of anaesthesia. So the data is quite old because it's probably from the early 2000s, but as I say, it's probably the only literature that we've got which actually puts a specific number on this increased risk of anaesthesia. And his study found that cats weighing greater than 6 kilos are nearly 3 times more likely to die in the perioperative period compared to cats weighing between 2 and 6 kilos. And in general, the reasons that obesity does present this increased risk of anaesthesia is twofold. First of all, we've got the functional effects of having all this excess adipose tissue deposited in different organ systems, and this has the effect on an animal's physiology and also their response to any drugs given. But also, a lot of people don't realise that being obese tends to put you into a low-grade inflammatory state, because adipocytes, which are fat cells, are endocrine cells. They produce adipokines, and these can affect homeostasis, so the way the body manages itself, basically. So the topics that we're going to cover this evening, I've tried to go pretty chronologically through the anaesthetic process. So starting with clinical exam and pre-op preparation, pre-anaesthetic medication, induction and endotracheal intubation, then anaesthetic maintenance, monitoring, and finishing with analgesia, fluid therapy, and recovery from anaesthesia. And for all of these topics, what I've done is I've split them into the challenges that we as anaesthetists face, and then the approach that the anaesthetist can take to meet these challenges and mitigate this risk. So you may think to yourself, oh, well, she's told me the problem, why hasn't she told me the solution? But believe me, it will hopefully be coming on the next slide. So clinical exam, and this can be really quite difficult in very obese patients. So especially cardiac auscultation, excessive fat can make it more difficult because you've got this standoff between where the heart is and where the stethoscope is. And so quiet murmurs, sometimes arrhythmias, you may not be able to pick up as well. Also abdominal palpation, peripheral pulse palpation if there's a lot of subcutaneous fat lying over arteries. And venipuncture in very obese patients can be more difficult to achieve also, again, because of subcutaneous fat lying over veins. And I think it's really worth highlighting to owners, especially if you're doing an initial exam while they're still in the room, that you've not been able to examine the animal as thoroughly as you would usually want to. There may be some mild or minor clinical abnormalities that are just not that apparent to you because of the animal's obesity that may affect anaesthesia. And they have to accept that risk that you may not have been able to identify these abnormalities because of the patient's weight. But it's important to do as thorough a pre-anaesthetic exam as possible, not just because of the obesity in itself and what this can mean to the respiratory and cardiovascular system especially, but also the link between obesity and other medical conditions. And so these can include diabetes mellitus, some cardiovascular and respiratory diseases, musculoskeletal disease, some skin diseases, and neoplasia. And these conditions in themselves might require further investigations and potentially stabilization before anaesthesia is performed. Now, you might be asking yourself, we've got a really fat patient coming in. Is it worth us putting them on a diet before we anaesthetize them? Well, certainly, preoperative weight reduction will reduce the risks and complications associated with anaesthesia. But it's not a good idea to put these animals on a crash diet for a few days beforehand. If you want to do weight reduction, which if there's at all the possibility that it's an elective enough procedure, such as neutering, that you could take several weeks to months, then absolutely getting that patient's weight down would be of a real benefit to them. But if you don't have that time and it's not an elective procedure, then crash diets should be avoided, because a lot of these patients are going to be insulin resistant. They might have aberrations in carbohydrate metabolism if you put them into a starvation mode before anaesthesia. So in general, we talk about, with our pre-anaesthetic starvation, and I mean by this to reduce our chances of regurgitation, making sure we have an empty stomach before anaesthesia, not starving patients in a diet kind of way. But we would recommend the current AAHA guidelines of 4 to 6 hours food withhold before anaesthesia and no water withhold, which means water gets removed at the time of pre-anaesthetic medication. So I'm referring quite a few times in this webinar to the AAHA guidelines. This is the American Animal Hospital Association guidelines that were released in 2020. And these cover lots of different aspects of veterinary anaesthesia for small animals. And one of them was talking about how our current starvation times are really quite excessive if you ask for patients to be starved from 10 o'clock the night before. Because often what we don't realise is that owners just tend to give these patients their normal evening meal, maybe at 6 o'clock. So by the time they've come into us, and then they're being anaesthetised, say at 11, they've had a huge starvation time. So we're really wanting to limit down that starvation time of only 4 to 6 hours. Now, I'm going to talk a little bit later about why these obese patients may be at a slightly higher risk of reflux or regurgitation. And it's another recommendation that's come out of the AAHA guidelines, that any patient that is prone to regurgitation or at risk of regurgitation during anaesthesia should be preloaded with omeprazole. And by that, I mean a dose the night before and a dose the morning of anaesthesia. And in my clinical practice, I tend to make this an IV dose of 1 milligram per kilogram, slow intravenous injection, approximately 2 hours before I'm trying to pre-med the patient, because that's the kind of time it takes for the omeprazole to actually change the pH of the gastric fluid. It's not going to change the incidence of regurgitation, but it's going to make the consequences a lot less negative. That was a double negative there, but it's going to be a less acidic pH if the animal does regurgitate. So that's something else to think about in your pre-anaesthetic preparation. So let's now talk about pre-meds. So pre-anaesthetic medication, it depends on how you were planning on giving your pre-med. Sometimes I find that I think I've injected IN, but actually it's IF, it's gone intrafat. And then I don't have good drug absorption and I get a poor effect of my pre-anaesthetic medication. And if you're giving any drugs that are actually intended for subcutaneous injection, you may find that they're delayed in onset because adipose tissue generally doesn't get great perfusion to it. Also, as we've mentioned already, if there's a large amount of subcutaneous fat covering vessels, then venous catheterization, if you're planning on an IV pre-med, may be a little bit more difficult to achieve in very obese patients. So one thing I would suggest is that when you plan your pre-med for an obese patient, you should really only aim for mild to moderate levels of sedation in these patients. And this is because they're very prone to what we call respiratory embarrassment. They're very prone to becoming hypoxemic and also hypercapnic. And so we'd like them to be aware enough to basically be able to sort out their own respiratory system. We don't want them too deeply sedated. And I'd always recommend after pre-anaesthetic medication that patients are observed, especially for these respiratory complications, until the time of anaesthetic induction. Now, if you were to want to give an IM pre-med, and you'll be grateful to know that when I play this video, it will play the right way up. So either go for a long needle, or in my experience, anecdotally, I find the neck epaxial muscles have less fat coverage on them in this patient. So the nurse here is just showing you the technique for the apaxial, the neck epaxial injection. She's identified where the spine is and the vertebrae, and then she's just moving off to one side because we've got the apaxial muscles that run up the neck either side of the spine. So we're just going one side or the other. And so that's just an anecdotal thing from my experience, that I find the fat coverage over the cervical epaxial muscles less than that over the lumbar. And therefore I tend to get better response if I do have to use an IM pre-med. If the dog or the cat is of a suitable temperament that you're able to place an intravenous catheter into their vein without any sedation, then most pre-anaesthetic medications, not all of them, can be used safely via the IV route, and that would give you a more predictable effect. Now, the age-old question, and this is quite controversial: do we dose for lean body weight? Do we dose for fat body weight? Do we dose somewhere in between? And my answer is it's not a clear-cut answer, and a lot of it depends actually on the route of administration you're planning for. So personally, if I was to be using an intramuscular injection, say for example acepromazine and an opioid, or an alpha-2 and an opioid, and I wanted to give it IM, I tend to dose it to the patient's actual body weight. And this is because when you give it IM, this drug will redistribute into all the compartments, including the fat. But we have to leave behind an appropriate plasma concentration that can be achieved and maintained. If we dosed for the lean body weight in that situation, by the time the drug had redistributed into the fat, we'd leave behind a lower plasma concentration. So you may not see the effect that you're wanting. So that's for IM. Personally, I say actual body weight for IM. If it was for IV though, if you went with that approach and you based it on the actual body weight, you'd find that you get a much deeper level of sedation than you were expecting, because we're going directly into the bloodstream and we're achieving a plasma concentration immediately. So personally, I go somewhere between lean body weight and fat body weight in that circumstance. Some people say dose for lean body weight in that situation. I go somewhere in between. And when I was reviewing the literature, I actually found this really nice, quite easy formula that human medical anaesthetists use in obese people. And they calculate the body weight that they use for dosing as the ideal body weight plus a third of the difference between actual body weight and ideal body weight. So that's a formula that you could use if you like going somewhere in between. So just to recap on that slide, because it's a question that a lot of people come up with, is if we're going IM, we go for the patient's actual body weight. If we're going IV, then we either go for lean body weight or somewhere in between lean and fat, but closer to the lean. So what about our anaesthetic induction? What are the challenges that are associated with that? Well, again, one of the challenges is about sort of the dose of drug, because most anaesthetic induction agents are lipid soluble. They have to be, because they have to be able to cross the blood-brain barrier to produce anaesthesia. But that means that if we use large doses of induction agents or repeated doses, then we have a big fat sink, which is our adipose tissue, that this drug redistributes into. And then it will have to come back out of that fat tissue, and clearance from this really large mass of adipose tissue can be sometimes delayed. And that means we have a slower recovery from anaesthesia. So that's one of the issues. And I'm going to come on to how we deal with that in a moment. The next issue that surrounds anaesthetic induction is this issue of esophageal reflux risk is a little bit higher in obese patients. And that's because the amount of intra-abdominal fat can increase intra-abdominal pressure, and that can increase the risk of reflux. And one of the real times of concern for the anaesthetist of a refluxing animal is at induction, when the animal has lost its pharyngeal and laryngeal reflexes, but we have not yet secured the airway and protected the airway with an endotracheal tube. So that's another concern we have for induction of anaesthesia. A final concern we have for induction of anaesthesia is the fact that patients that are obese tend to desaturate, which means that their oxygen saturation, their SpO2, quite often drops, sometimes really substantially. And this is because the obese animal has a lower functional residual capacity, or FRC, compared to animals of a lean body weight. So just as a reminder of your respiratory physiology, if you have a look at the graph in front of you, FRC, or functional residual capacity, is the combination of the expiratory reserve volume and the residual volume. So basically, at the end of a normal breath out, that's the amount of air left in your lungs. And the reason that we as anaesthetists get worked up about patients with decreased FRCs is that the FRC is the inter-breath store of alveolar oxygen. So if we have a decreased FRC, it means that our patients have less of a store of oxygen in between their breaths. And that means they're going to be more prone to desaturating. So what can we do clinically to try and prevent this from happening? Well, pre-oxygenation by mask is a very easy way of doing it for between 3 and 5 minutes. And you might sit there and think, oh, that just is going to take forever. Well, actually, by the time you've attached your blood pressure cuff, put some ECG pads on, maybe done a checklist if you do checklists in your practice, really that 3 to 5 minutes, that will all be, it's not wasted time. Ideally, we would always choose an IV induction compared to an inhalational induction, for example, with a mask. Now, I know I've talked about how any IV drugs you give are going to redistribute partially into the fat compartment, but this is all about trying to achieve endotracheal intubation as quickly as possible, because there may be this esophageal reflux. And mask inductions, first of all, aren't very nice for the patient. They're a great pollution risk, but also they take a lot longer to achieve airway security. So I'd always suggest IV induction. But one thing you can do, I'm just going to play this video now, is what's called head-up induction. And this is one of the ones that I use to prevent esophageal reflux during induction of anaesthesia. So you can see that the nurse is restraining this dog in sternal recumbency, and she's supporting the head well above the level of the chest. And this technique uses gravity to try and avoid any stomach contents coming up into the mouth. And we're going to keep the head up until the endotracheal tube is in place. And also you'll notice that we do a little bit of cuff inflation so that we've got somewhat of a seal. We'll then continue later to do a leak check of the cuff. But we're going to intubate the trachea, do a little bit of a seal before we allow the animal's head to come down. And this is just, as I say, a very low-tech way of using gravity to try and avoid any regurgitation happening. And I use this in patients that I'm worried will regurgitate, vomit. Maybe they have a full stomach because they've not been starved because it's an emergency. So it's quite a useful, simple technique to do. Now, what about the actual doses of the anaesthetic induction drug? Well, we're only looking for a rapid increase in the brain concentration. So in general, we should be able to dose for the lean body weight in this situation, because we're going to pretty rapidly increase our brain concentrations to get the initial induction effect of the drug. And then for maintenance, the volatile agent's going to take over. And we have a nice little bit of evidence for this from Bovary et al. In 2013, where she looked at doses of propofol needed to allow endotracheal intubation in fat dogs and normal weight dogs after they'd been pre-medicated with dexmedetomidine and butorphanol. And she found that the propofol dose was significantly lower in the obese dogs compared to the normal weight dogs by a matter of about 0.5 mg per kg almost. And that's because the obese dogs were actually just needing their lean body weight propofol dose, and that's why it's come out as lower. But in general, I'd always suggest with induction agents to go slowly to effect. Now, I know we have to weigh up the pros and cons of slowly to effect so that we can reduce the total amount of induction drug we give to our patients, but we also want to go fast enough that we can obtain endotracheal intubation as quickly as possible. But there's certainly no need to, especially after these kind of alpha-2 butorphanol sedations, you know, bang in 4 mg per kg of propofol. It just isn't necessary to go that high. Now, what about endotracheal intubation in itself? Well, this can be complicated in obese patients because they may have very excessive fatty tissues in the oropharyngeal area, and that can actually narrow the lumen of the upper respiratory tract, or it can make visualization of the airway difficult. Also, we have to remember that there are certain upper respiratory tract diseases, including tracheal collapse in small animals, in small dogs, and laryngeal paralysis in larger breeds, that can actually worsen or be precipitated by patients becoming obese. So how do I manage my endotracheal intubation? Well, again, our pre-oxygenation buys us loads of time if we are going to have trouble intubating our trachea. It gives us a nice full pair of lungs with oxygen, which means that if we've got any trouble intubating, we just buy ourselves a lot more time. I tend to have a wider range of ET tubes, and a laryngoscope also helps. If you are concerned about the regurgitation or reflux risk of your patient, maybe having some nearby suction can be beneficial. Now, personally, in an obese patient, I'd always use a cuffed endotracheal tube, because I think there's a pretty high chance that you might have to do IPPV at some point, and that will be facilitated with a cuffed ET tube, and also you're going to have less pollution risks. Also, if we have got esophageal reflux happening with a cuffed ET tube, we'll have better airway protection. But I'm sure I don't need to tell you about the care of inflating cuffs in cats' ET tubes, and to make sure that you're not overinflating them. So personally, with all ET tubes where I'm cuffing them, I would use an incremental inflation technique, whereby the person anaesthetizing the patient listens at the head end for a leak when someone else is squeezing the reservoir bag, and just incrementally increases the volume of air in the cuff of the pilot balloon until the leak just stops. We've also got manometers that we can use to check cuff pressures as well. Now, it may be that you are having to do sedation for these patients, heavy sedation, for example, for orthopedic radiographs. With those patients, we've still got the risk of regurgitation, but because they're sedated, we can't place endotracheal tubes down them. But there are supraglottic airway devices, such as these laryngeal mask airways. I don't know if any of you are familiar with them in the bottom picture, that can be placed in sedated patients, that they're not as good airway protection if there's regurgitation as an endotracheal tube, but they're certainly better than just a mask or nothing at all. So what about maintenance of anaesthesia and monitoring? What are the changes there, or challenges there, sorry? Well, we are used to battling hypothermia during our anaesthetics. However, with patients that are very fat, because of the natural insulation that comes with that, we actually may get hyperthermia, and in very hot conditions, there have been reports of heat stroke actually happening. Other concerns we have during maintenance of anaesthesia is that obese animals are very prone to what we call respiratory embarrassment. And this is for multiple reasons. We've got that reduced FRC, which remember means that the patients are more prone to being hypoxemic. We've also got, because of the large amount of intrathoracic, extrathoracic and abdominal fat, this decreases chest wall and lung compliance. And compliance is a measure of the lung and the chest wall's ability to stretch and expand. So if we say we have a low compliance, it means that we've got stiff lung tissue and stiff chest walls. We also have a decreased total lung capacity in these patients. So total lung capacity is the volume of air contained in the lungs at the end of a maximal inspiration. We've also got a greater risk of what we call VQ mismatch, or ventilation perfusion mismatch. So a ventilation perfusion mismatch is when we have parts of the lung that get well oxygenated but not good blood flow to pick the oxygen up, or they have good blood flow but they don't have very good oxygenation. And for all of these reasons, obese patients during an anaesthetic are a lot more prone to hypoxemia, and they're a lot more prone to hypercapnia during the anaesthetic. Other challenges we face with maintenance and monitoring are that we can also have morphological cardiac changes and also associated cardiovascular effects because of the inflammation that comes with obesity. So I think we always have to keep a high level of suspicion regarding the likelihood of cardiovascular disease in obese patients. So when we talk about monitoring our cardiovascular system, we're mainly looking at ECG and also blood pressure monitoring. But blood pressure monitoring can be complicated in the obese patient, mainly because of the amount of fat overlying these peripheral arteries. If you like cannulating arteries to do direct blood pressure measuring, that can be more difficult to perform. But even if you're using indirect monitor, such as the oscillometric blood pressure monitors have things called piezoelectric crystals in the cuff that needs to detect movements of the artery below the cuff. But if there's a large amount of fat that's sitting between the cuff and the artery, then sometimes that can give you some really duff numbers. So what are our approaches with anaesthetic monitoring and maintenance? Well, whilst I said that injectable agents were preferable to induce anaesthesia rather than inhalational, the pharmacokinetics of inhalational agents for maintenance of anaesthesia are more predictable. So I'd always suggest a volatile agent maintenance for these patients, not maintaining them on IV agents. The amount of drug that you would give them, that would be coming out of their fat deposits for hours and hours, and you'd have potentially a very delayed recovery from anaesthesia. Monitor as many of the organ systems as you can, because obesity has the potential for causing dysfunction of lots of them. So body temperature, yes, capnography, blood pressure, ECG, pulse oximetry. With the blood pressure, if you're finding your oscillometric is problematic, then Doppler blood pressure can sometimes be a bit easier to use. We are expecting respiratory embarrassment in an obese patient. And so pulse oximetry and capnography would be one of the most useful monitoring types that I would want to use in these guys. And that may lead you on to having to provide positive pressure ventilation and ventilate the patient's lungs. This could improve poor SpO2, but it certainly is the treatment of choice if the patient becomes hypercapnic because it's hypoventilating. And some ventilators will allow you to add PEEP to it by incorporating a PEEP valve. So PEEP stands for positive end expiratory pressure. And it's a mode of therapy that's used where basically this valve doesn't allow the lungs to empty fully at the end of expiration, and the pressure in the lungs is maintained above atmospheric pressure. And it's there to try and prevent alveoli from collapsing, and also recruits closed alveoli to improve oxygenation. But if you do have a ventilator in your practice, just make sure that you're using tidal volumes of the lean body weight, so 10 to 15 mil per kilo. Positioning during anaesthesia and moving patients can be complicated, not just for the patient, but the health and safety of the staff involved if they're lifting quite a large kilo weight. So we have to be very mindful of how we move and position these patients. And especially it's dorsal recumbency that's one of the greatest concerns for the anaesthetist in the obese patient, because then we have a large amount of intra-abdominal fat mass that can basically press forward on the diaphragm, limit the tidal volume, and again, limit that FRC, but also it can cause compression of the aorta and the vena cava. And this can reduce our venous return back to the heart, which in turn could decrease our cardiac output, and therefore we might see this with our blood pressure decreasing. We also have to take into account that a lot of these obese patients have osteoarthritis because of their weight, but also their pro-inflammatory state. And so if we position these guys poorly during anaesthesia, we may get them recovering from anaesthesia a lot more painful and stiff than when they went in. So how can we deal with this? Well, trying to use appropriately sized tables and gurneys, having sufficient staff numbers, and maybe using things like PAT slides to help transfer patients between stations. And this especially will avoid putting excessive tension on a particular part of the animal's body to move them. Try and choose operating tables that have a decent width to them, especially if you've got a patient that's in lateral recumbency and the table's too narrow and there isn't support of their limbs. You can get neuropraxia from stretching of nerves with limbs hanging down. So try and make sure animals' limbs are supported. Do good padding, do good positioning. Don't tie legs down too sort of acutely, because that would certainly worsen pain associated with the osteoarthritis. And if you are anaesthetizing a patient in dorsal recumbency and you have the possibility of tilting a table, then they may benefit from a slightly head up position, because this will tilt or tip the abdominal contents away from the diaphragm somewhat, and so the respiratory embarrassment will be lessened. Another thing to say is if you're having to change the animal's body position, either for clipping and prepping, an orthopedic case, or maybe an abdominal ultrasound, try and make the changes to the body position a little slower. Don't just go from left lateral recumbency directly into right lateral recumbency, because you may see desaturation of the patient. If possible, have like a halfway house where you go into dorsal recumbency for a few minutes, just to allow changes to be made inside the lungs. If there's any clipping or any ultrasounding, depending on what the reasons that they're being anaesthetized for, can be done in that position before you move them into the other recumbency. What about perioptive analgesia? What are our challenges? Well, I'm an absolute sucker and a great fan for local anaesthetic techniques. And it's certainly one of the things I can help you with if you want to get into doing locals, but you need some live guidance because you're just not familiar with the technique and you want a helping hand. That's absolutely the kind of thing I'm here for. But actually doing local blocks when you're looking for anatomical landmarks in very obese patients can sometimes make it really quite difficult. And so I wouldn't suggest starting off with an obese patient for the first time you're, say, for example, trying to do an epidural injection, because you need to be able to palpate the right bits of the pelvis to know that you're in the right place. But let's say we were able to obtain an epidural injection. You've got to be careful of the volumes of drug that you're giving, because they will spread more cranially in an obese animal compared to how cranial they'd spread in a lean animal. And this is for a few reasons. The first is that the animal's epidural space hasn't put any weight on, just the animal. So it's probably still got the same volume of epidural space that it had when it was lean. But also now we sometimes have fatty deposition in the epidural space and epidural vessel engorgement that can take up more room. So now if we give a local anaesthetic injection, for example, into the epidural space, it will spread more cranially. And if it spreads to the thoracic segments, then that can cause potentially more respiratory embarrassment. We've also got to take into account that a lot of these patients may be presented already on non-steroidals because of the high incidence of orthopedic disease. that happens with them. And so when we make our analgesic plans, yes, we want a multimodal approach to analgesia. So that would be thinking about drugs such as opioids, local anesthetics, NMDA antagonists such as ketamine, alpha-2 adrenergic agonists, nitrous oxide if you've still got it, and yes, maybe non-steroidals, or in the case of the dog, paracetamol. But with an NSAID, I'm always a little bit mindful that I can't always guarantee normal blood pressure throughout the anaesthetic with one of these patients. And so often I will withhold the non-steroidal around the time of anaesthesia. I might by injection as they're recovering once I know that things have gone well and I've been able to maintain a good blood pressure. And as with other animals, we need to be withholding NSAIDs if a steroid is in their near future, or if there's concomitant renal problems, any gastrointestinal problems. So the usual rules apply, but I just think it's a lot more likely that these patients will come to you already on a non-steroidal drug. Now, with local blocks, one of the lovely things we can do with local blocks is that some of them that have a motor component, we can use electrical nerve stimulation to help guide us. And this would really help if the bony prominences aren't as obvious. And some anaesthetists will also work with ultrasound guidance as well. So those are always really useful to do with, say, for example, femoral sciatic blocks that have a motor component to it. If you are planning on doing an epidural, then personally, I tend to reduce my volume of injectate, first of all, back to lean body weight, but approximately 3/4 of the original dose that I was planning. And nitrous oxide has gone out of favour a lot because of the environmental impact that it has on our greenhouse gases. But if you are still using it in your practice, yes, use it as part of a multimodal analgesia approach, but it will limit the fraction of the inspired oxygen that's available to the patient. So you just need to make sure you're monitoring SpO2 whilst you're using it. And if your SpO2 drops below 95%, then discontinue the nitrous at that point. Fluid therapy wise, yes, we'll have an increased overall blood volume, but on a ml per kilo basis, it will be lower in obese animals. For assessment of hydration status, if you're thinking about replacing fluid deficits, for example, it can be a bit more difficult to assess hydration in an obese patient because the skin tent test, you will, in a dehydrated obese patient, the skin tent will still return to normal immediately. And this is because of the very high adipose and therefore water content of the skin. So just be mindful that you won't be able to do that assessment. You need to think about other components of it. And in general, we don't have much literature as to adjusting fluid therapy requirements in obese patients, even though we know that increased body fat will likely decrease our total body water. So how do we approach fluid therapy? Well, first of all, if we're assessing dehydration, try and use some objective measures such as USG, PCV and total protein, urea, as well as other subjective measurements. So you can look at tackiness of mucous membranes, you can look at sunkenness of eyes, and these should still be relevant in the obese patient. Remember that coexisting endocrinopathies that obese patients may have can influence electrolyte and acid-base balance, and I would always check for these. But otherwise, if you're thinking it's a fairly uncomplicated anaesthetic, then generally I would follow the same guidelines. I haven't got any suggestions for you as to increasing or decreasing the amount of fluid therapy. So the AAHA fluid therapy guidelines, which we've taken from 2013, for anaesthesia certainly, are that in dogs, we start with an average initial rate of 5 ml per kilo per hour, and in cats, 3 ml per kilo per hour. And this is of crystalloids such as Hartmann's. And then if the anaesthetic procedure lasts for greater than an hour, then we reduce the fluid therapy rate by 25% every hour until the patient's maintenance rate is reached. That's assuming the patient remains stable. Obviously, if they become hypotensive, then you may need to take fluid therapy up, for example. But another thing I just want to point out here is I think that a lot of people still think that maintenance is 2 ml per kilo per hour, and that certainly isn't the case. Maintenance fluid therapy, which is basically just matching insensible and sensible losses in a patient, is related to metabolic size and allometric scaling. So in general, the bigger the body size, the lower the mil per kilo per hour. And so there are two formulae here, which use 0.75 to the power of 0.75, which is a function on your calculator you'll be able to find, that you can calculate your patient's maintenance rate. It will give you the volume, the total volume in 24 hours. So don't be surprised if you get volumes in hundreds or 1,000 and something. You need to divide it by 24 and then divide it by the patient's body weight again to get the mil per kilo per hour. So just to recap, for the fluid therapy guidelines for any healthy-ish, as in not in congestive heart failure, not in acute kidney injury patients, so healthy-ish patients, we're looking at 3 mil per kilo per hour initial rate for the cat, 5 for the dog, and then after an hour we reduce those rates down by 25% every hour until the maintenance rates are reached. But just remember, maintenance is not always 2 mil per kilo per hour. And then finally, just moving on to recovery from anaesthesia. So this may be delayed because if surgical access has been more complicated because of the patient's body weight, it will prolong the anaesthetic time and potentially prolong the recovery from anaesthesia, especially if the obesity has been complicated by any diseases that have impaired hepatic function. But we have to remember that when we move animals through into recovery, we're often taking away all of the supportive measures that we give them and a lot of their monitoring. But the respiratory embarrassment and other, say, sedative effects of the drugs will still be on board. And so we've got to be very cautious about airway protection and cautious about their risks of hypoxemia if we don't carry on oxygen supplementation. We've also got the possibility, and I know that this sounds counterintuitive with obese patients, but we don't want them to have post-anaesthetic inappetence for a long period of time, because that can really have some detrimental effects on them, similar to what I was talking about not crash dieting them initially. So ideally, we would have picked short-acting drugs, or those that could be antagonized, or those that have minimal sedation hangovers, so that we get them with a fast return to consciousness so they can look after their own airway. And we want to make sure they're well analgesed as well, because if they are comfortable, they're going to be more likely to eat post-operatively. If there's been any reflux or regurgitation during anaesthesia, I tend to do some suctioning to clear out any fluid or debris. I leave the cuff up in the ET tube until the animal is vigorously swallowing. Now, this is relevant for the dog. In the cat, their sensitivity of the laryngeal mucosa is such that I tend to wait for one swallow, then I deflate the cuff and extubate. And you could consider continuing the omeprazole that hopefully you've preloaded with. Once you've extubated, just make sure that the animal's airway is patent. So hand in front of the muzzle, just to make sure that you can feel the airflow. Checking the saturation with a mobile pulse oximeter, as you can see in this photo, and supplementing oxygen if necessary. Again, another thing from the American Animal Hospital Association 2020 guidelines, they've suggested that the monitoring of the recovery period is as important and should be done with the same vigilance as monitoring during anaesthesia. And they're suggesting that we check heart rate, respiratory rate, SpO2, blood pressure, and body temperature until the patient is alert, normothermic, and ambulatory. So in conclusion, we're seeing obese patients more and more commonly in our small animal practices. And obesity does present a problem for the anaesthetist for two main reasons: the sort of functional effects of a large amount of fat around different body systems, but also this creation of the low-grade inflammatory state. You are going to find challenges at every stage of anaesthesia. However, hopefully I've made some clinical suggestions to you that can try and mitigate the risks involved. Thank you so much for your attention. I'm very happy to take any questions. Now, I appreciate that that normally requires people typing into chat boxes. So, so we don't sit here in an awkward silence for the next 2 minutes. I just wanted to give you some indications of the kind of things that I can do to help you in your practice. So I've already mentioned about helping you create bespoke plans for complex anaesthetic cases, but also, if you wanted me to, I can stay and literally be your hands-on anaesthesia assistant during a difficult anaesthetic. I can help you interpret the monitoring of the vital parameters. I can help you make decisions responding to any changes that you see during the actual anaesthetic. For unfamiliar procedures that you want to try, such as local anaesthetic techniques, central lines, arterial blood sampling, for example, I can give you live guidance for that. And then if it's just general specialist advice that you want on anaesthetic related issues, like creating new SOPs, finding the best best practice for clinical audits, for example, or even if you're introducing a new drug into your practice and you want some help, then these are all the kind of things that I can help you with. But potentially we've got some questions, so I'm very happy to take any of those. Thank you.
Thank you, Nikki. That was absolutely brilliant. I definitely learned a lot. I'm sure other people have. We've had a few questions come in across on WhatsApp. Please do, there's a little question and answer box on the bar below on your Zoom if you have got any questions for Nikki. We've had one question just asking if you could go into a little bit more detail about the laryngeal masks, as they haven't come across these before.
Okay, so the laryngeal masks, or you may have heard, well, I use the term LMA, is an example of what we call a supraglottic airway device. So those of you that use V-gels in rabbits or cats, that's also an example of a supraglottic airway device. And basically, instead of going into the trachea and through the larynx, it sits over the larynx. And so it does provide some airway security. It's not as good at preventing any reflux that came up going down the airway, but it's certainly better than nothing at all. And the great thing is it can be used in just deeply sedated patients. You don't need to have them anaesthetized to be able to place one of these. So for example, if I have any brachycephalic patients that I've only got permission for sedation for orthopedic radiographs, or an obese patient, I will often do maybe an alpha-2 butorphanol, and then I find I often have to use some midazolam as well, just to deepen that level of sedation. And then it's just a matter of looking down the airway with the laryngoscope, selecting the right size. And the ones that I showed you in the photo, there's a variety of sizes. They're human pieces of medical equipment. You can buy them for a variety of sizes that work with a lot of different breeds of dogs. And so I tend to use these in dogs pretty much exclusively. And then, yeah, just place it over the top of the larynx. I tend to use a capnograph to ascertain that it's in the correct place. I want a nice steep upslope on the capnograph showing that there's no obstruction. But yeah, they're really nice little pieces of kit, not expensive, can be sterilized in between patients. And again, this is something I can help you with. If you want to start trying them and you want some help, then I can certainly talk you through it.
Thank you. We've had another question pop up. Thank you, Jodie, for your question. Would you mind briefly explaining the part on Bovary 2013 regarding propofol dosing in obese patients? I think everyone just wants to make sure that they definitely understood that and take away the right message from that one.
Yeah, no problem. So the Bovary study showed that I think it was 1.8 mg per kg was needed to induce the obese patients, but 2.2 mg per kg of propofol was needed to induce and be able to endotracheally intubate the lean body weight patients. So what this to me is saying is that the obese patients only needed their lean body weight dose, and that is why they took a lower dose. So it just was supporting what I was saying about for your induction of anesthesia. You should be aiming for lean body weight doses, not fat body weight doses, because we ultimately just need a high enough plasma concentration that goes to the brain before anything redistributes into fat. to, be able to achieve that anaesthetic effect, to be able to place the endotracheal tube. Does that make sense? I'm very happy if Jodie says no and she wants me to go through it a different way. I appreciate it's sometimes a concept, it takes some getting your head around.
And then we have another question through. Is there a maximum amount of air you would put into a cuff before it would be better to replace the tube with a larger one?
Oh, that's a great question. So I suppose it depends on what kind of endotracheal tubes you're using and whether you're using, and maybe they can reply to me, whether you're using red rubber or silicone or PVC, because you've got some cuffs that have a squarer profile, which we call a low pressure, high volume cuff. And we've got some cuffs which have a more rounder convex, like a curved profile, which are a higher pressure, lower volume cuff. So I don't know if they've replied to.
We haven't had a reply through yet, but we have had a reply from Jodie who said thank you.
Okay, no problem.
Thank you, that was covered everything.
Yeah, no problem. So I would say if I was looking at an average sized dog and I had one of my high volume, because I'm just thinking clinically what I would do, if I had one of my high volume, low pressure cuffs in, if I was giving much more than 10 mils, I'd probably think about changing.
We've just had a response. It's the clear silicone tubes they're using. Thank you
so that, no worries, thank you. So the silicone ones tend to be a more the more concave, the more curved ones. So for those, yeah, it depends on the size of the dog. Sorry to be wishy-washy about this, but it would depend on each individual case. But I'm saying for an average size, say 20 kilo dogs, if I was putting more than 10 mils in, I'd think about maybe changing for the size up. My old adage with placing endotracheal tubes was go big or go home. But what I realized is that some people thought that meant hitting every tracheal ring on the way down. And that is not what you're looking for. You don't want to be causing any damage, but you certainly want a well-fitting endotracheal tube. And I would always advocate the incremental inflation technique so that we don't do any damage by overinflating cuffs and causing tracheal necrosis. So if anybody needs me to go through that technique again that I described, then please do ask.
And do you have any tips for how you'd choose the tube size? Would you normally have a few available and then have a look at the back of the throat and then make a decision? Or do you have, is it something you've just got more experience with time?
I would hope that I'm very experienced after 20 years. But yeah, I mean, when I used to teach students, I used to say 10 millimeter for a 20 kilo dog and then extrapolate up and down. But actually, if you've got an obese 20 kilo dog that's actually eaten a 12 kilo dog, then that's not going to really help you. There have been some people that describe literally palpating the trachea through the tissues of the neck to give you an idea of what size you're putting down. I've also heard people using a technique where they look at the area. If you look at a dog's nose, which I imagine wouldn't put weight on when they got fat, but if you have a look at the dog's nose and where the nostrils are, the kind of surface area of the space underneath the nostrils, some people say is a little bit similar to the bore of the endotracheal tube you can place down. Now, I've never checked that out because I've always been a pretty good guesser at what kind of tube size I'm going to get down. And I think it's something to be said, I said about having a wide range of endotracheal tubes. And it's for that reason, you might be really surprised when you go to look in the mouth of how small the tracheal lumen is. And so I think having a range of endotracheal tubes, and then once you've seen, you can pick from there, especially if we're talking about fat brachycephalics. I had a 31 kilo English bulldog, last Wednesday, and I fitted a 5.5 ET tube down him, and he only needed 2 mil seal. So it wasn't even because I was being like really wussy with my ET tubes. So when we're dealing with brachycephalics, obviously they have much smaller tracheas than we're giving them credit for.
I'm glad you mentioned the Nostril Trick. That was something I was taught as a new grad and used it quite regularly in practice. So I'm glad it wasn't just something
I described it the way that you were taught it, because it's not something I've ever used, but the Nostril Trick is
Yeah, it
a
worked a
new
treat for
thing.
me. It was good. We've
Okay.
got another one. It's not directly related to the lecture, but you mentioned epidural anesthesia.
Mhm.
Could you give an idea of what sort of procedures you would be using epidural anesthesia for?
Oh, epidurals are amazing and you can use them for loads of things. So primarily, I suppose, hind limb procedures, so orthopedic procedures. And certainly with things like femoral sciatic blocks, which I think a lot of people have moved on to, that's really only going to desensitize the stifle and below. Whereas the epidural, if you had, say, a femoral fracture or, you know, things higher than the stifle, will still cover for that. So hind limb orthopedic procedures, tail procedures, so tail amputation, and perineal procedures, so anal furunculosis, perineal rupture repairs, abdominal procedures, so XLAPs can be really useful in. I will often do high epidurals with usually missing out the local, but you can still give morphine in a high epidural. And that means that I'm using a larger volume to spread it into the cranial, into the thoracic segments. And then you could get really lovely analgesia for thoracic procedures, forequarter amputations. I've used epidurals on really troublesome pancreatitis patients.
Oh, wow.
There's all kinds of things. I've even heard of epidurals being used for saddle thrombus cats, whereby it's good analgesia because they're often screaming in absolute agony. But also, if you use a local anesthetic, it can actually contribute to vasodilation of the blood vessels in the affected area. Now, personally, that's not something I use because in my vets now experience, having been an emergency vet as well for many years whilst I was doing my PhD, for example, I didn't do all that well with saddle thrombus cats. They tended, the owners tended to make a decision there and then. So I didn't ever try and manage any, but I've even seen reports of that. So epidurals, brilliant things, love them.
Great.
Loved mine when I had my twins by cesarean.
Lovely. Well, I think that is all the questions that I can see. Let me just have a little check. I don't want to miss. Oh, sorry, there's a few more.
Okay.
Respiratory embarrassment. Or how would you describe that? Is that like breath holding?
No, it just
As we
means that I would say they're in the nicest possible way respiratory cripples, and they're basically just a lot more prone to becoming hypoxemic or hypercapnic. They're not going to sort out their own ventilation as maybe a normal animal would, because of all of those things about VQ mismatch and compliance and FRC. They're just going to be much more prone to being hypoxic and hypercapnic. That's what I mean by respiratory embarrassment. Yeah. And
then we have a question: how do you feel about using safe seal endotracheal tubes?
Oh, exciting. I have never clinically used them. So are these the ones, can I just check with the delegate that I'm answering about the right one, was with the baffles and not the cuff? With bated breath.
I know.
Come back to
The joy of technology, I think. And then we had another one asking, do you give any credence to measuring the, I'm terrible at say the filtrum to pick a tube, so that's good. I'm glad we covered that. She said yes with the baffles.
With the baffles. Okay, so the safe CLET tubes are a cuffless system that are available, if you get me right, in a variety of sizes, and they have these baffles. So basically, I don't know how to describe them. Basically, these little ridges over the part of the ET tube where the cuff would be. And so when you intubate the trachea, they go in nice and smoothly, but then they sort of sit proud and they're there to try and prevent any reflux or regurgitation going down past them. And then they have the added benefit, purportedly, of when you come to extubate the trachea, that they may well squeegee some of the reflux or regurgitation in front of them to come out. Clinically, I've never used them. Thinking about it, I am suspicious that the range of sizes that they say you could place the tubes in with the limited sizes they produce, you might not always be getting great airway security. And personally, I don't think you could ever get better than a cuffed ET tube. So that's but I've clinically never used them. So I'm sorry, I can't actually give you personal experience details from it.
No, that's brilliant. Well, thank you very much, Nicki. I think that's all of our questions answered. If anyone has any additional questions, feel free to message us on the VVS group or send us an email. We can pass those on to Nicki. But I just want to say a big thank you to Nicki. That was so interesting. I've definitely learned a lot. And thank you to everyone for coming and joining us on your Monday evening. And hopefully we'll be able to produce a few more of these live webinars over the coming months. And please do give us your feedback. Let us know what you thought of it, if there's any particular topics you'd like to hear from. And if you would like to speak to Nicki about a case, then please do get in touch.